Dear listeners, welcome to the MI Mental podcast. My name is Sabine Fonderson, a GP. Today, I'm going to talk about the case of an anesthesiologist who went off label. On the night of 10th to 11th of November, the wife of a COVID 19 positive patient was at home. She was seeing that her husband was suffering and he was also on oxygen therapy. Unable to get a GP from out of hours practice, she turned to her friend, who in turn gave her the number of an anesthesiologist. We'll call him Dr. A moving forward. Dr. A arrived the next day to her house to see her husband, who was at the time 70 years old. And as I said, he had been diagnosed with COVID 19 and was at home on home oxygen. He administered an ampoule of Enoximone, and the drug is typically used to treat heart failure. The anesthesiologist, Dr. A, had checked the vital signs, including the blood pressure, the pulse, and saturation. And after giving 20 milligrams of Enoximone, he noticed that the patient seemed to respond quite well. He then left the patient with a prescription or a repeat prescription of 20 milligrams of the drug to be taken orally every day. Dr. A had no prior contact with this patient before and had not disclosed to the patient's GP what he had done. He also prescribed the medication without informing the patient of the side effects and without giving any follow-up treatment plan. After prescribing the repeat prescription, Dr. A decided to contact the patient's GP. The GP realized upon speaking to Dr. A that this patient was not well informed about the off-label use of Enoximone, and Dr. A had very little knowledge of the patient's full medical history. The GP checked on the patients every day, either by phone or by home visit. But despite this, Dr. A still went and prescribed the medication. The GP finally alerted the medical inspections office about this case. Now, it turns out that the medical council already knew about Dr. A off-label prescription and use of Enoximone. Since 2020, he had given this to other COVID 19 positive patients. And the same doctor had reported that he administered this drug to patients. So why did he do that? It turns out he had to report the off-label use of the drugs. Around COVID time, or the pandemic, there was a high demand in the use of off-label drugs like ivermectin and chloroquine. And the medical inspections officers had stated that doctors would be fined for off-label drug use of these drugs, a fine of up to 150,000 euros. So upon hearing this, Dr. A had, in fact, in April of 2021, alerted the medical council and inspections that he was using off-label Enoximone. At the time, the inspection concluded that he clearly acknowledged the use and he was aware of the medical regulations, and they left it at that, basically saying that, well, you know what the medical regulations are, so we expect you to do the right thing. So now, once the GP of the 70-year-old patient filed a report, they had to come up with a new investigation. The inspections concluded that the anesthesiologist, Dr. A, had actually acted against the medical regulations and the law at the time. Dr. A appealed this decision, claiming, well, I acted the same way I would have if I treated asthma patients, and besides, COVID pandemic should be seen as an exception. Plus, this patient would never have stood a chance to be placed on ventilation had he remained in hospital because he was over 70 years old. Dr. A went on to say, "Well, I'm an experienced doctor and I stand by my decisions and will continue to treat patients with enoximone as I have done in the past because several of my patients have really benefited from this, and I have sworn an oath. I am here to look for the best treatment for each of my patients." Well, the medical council disagreed, and they ended up reprimanding and issuing a warning to Dr. A. And the arguments were there were no protocols on the use of enoximone as an off label treatment in COVID 19 positive patients, and there were no protocols that were even being developed at the time. Furthermore, the Pharmaceutical Federation explicitly did not recommend this treatment for these type of patients. They also found that Dr. A did not act according to safe medical practice. He did not assess the contraindications with the patients or with the GP, nor did he monitor the patient carefully. Plus, he administered the drug in November of 2021, when by that time, the COVID pandemic had already reached its peak a few times, and there had been multiple protocols and recommendations, which frankly had been stated by the Federal Medical Council. Dr. A also failed to monitor the patient. He had seen the patient just once, in the 2 months that he had written the repeat prescription. Also, the fact that Dr. A did not consider the side effects, for instance, of diarrhea and an irregular pulse, which the patient ended up having, gave the medical council some really grave concerns. This means for them that Dr. A did not monitor or at least provide some form of follow-up care after the treatment was given. In conclusion, the medical council found that Dr. A did not inform the patient's GP, did not provide adequate monitoring, and given the fact that he remained steadfast in his opinion, they find that he had no insight in his actions, and he has admitted during the trial that he will continue to prescribe enoximone. And for these reasons, they reprimanded the anesthesiologist and issued him a warning. So what can we learn from here? There are a few things we can really learn from this lesson in this case. Number one, and I've been in this situation before where as a doctor, I get friends of friends of friends that call me and ask me, what would you do? Can you help? Etc. Now, sometimes I want to help and I have been in a situation where I could, but I always say, have you discussed this yourself with your own GP? Have they discussed it with their own GP? A few months ago, I was asked by a friend of mine to give some advice regarding the son of her neighbor who had gone to hospital and had a really low hemoglobin level, and they wanted my opinion. And I said, well, I can't give an opinion because he's under treatment by a specialist, and I would rather that the specialist take care of him because that's what they're supposed to do. So part of being a doctor is also part of saying no. Yes, Dr. A said here he's a doctor, he took an oath, and he will always provide the best treatment for his patients. But I wonder if at this stage, the patient that he went to see, the 70-year-old COVID-19 positive patient, was that really his patient at the time? Was he in a state of medical mind, let's say, to treat him as a patient, especially when it was in a home setting? And yes, he might have thought that this patient would never stand a chance to be put on ventilation or hospital. But at the end of the day, this 70-year-old man on home oxygen was being seen by his GP every day. They was being monitored either through telephone or home visits. And yes, it's unfortunate that at that particular night, the wife was not able to get a GP from the out-of-hours services to come to her home. But that doesn't mean that Dr. A could just go in there and decide what treatment would be best for this patient. Another thing we can learn from this is that this doctor, the anesthesiologist, seemed not to have any insight in what he had done inappropriately. He stayed and remained steadfast that no matter what, he was still going to continue giving Enoximone to patients, despite the fact that the guidelines suggested that it should not be given as an off-label drug in COVID-19 patients. So he himself is going against the guidelines. So what are the things to know regarding off-label use of medication? The law suggests that the use of off-label drugs is admissible if within the specialty there is a protocol or there is a development of a protocol, and the doctor should discuss this use with a pharmacist in order to assess whether it's safe and whether or not it makes sense, and other options must have been completely ruled out as not being effective. Now, there are lots of lessons learned here, and I think this is a great case how doctors should be able to assert their authority and sometimes say, no, there was no need for him to go and treat this patient, especially without confiding and discussing this case with his own GP. What do you think of this case? If you have any questions or you have any remarks, please let me know, because I think this is a great topic to shed light into what we as health professionals should do and shouldn't do. And again, we should be encouraged to always do the best within our medical knowledge.